Welcome to the European Patient Safety Foundation and our conference together with the Austrian Network for Patient Safety and also the Medical University of Vienna, where we are today. It's a wonderful venue, I think. Thank you for being here. My name is Pernilla Gunther. I'm the president of the foundation, and we are doing this kind of patient safety conference for the second year. And of course, we hope that it will follow a number of years and also in different countries, because we do feel that the name, the European Patient Safety Foundation, is really something that we should be out in all European countries to talk about this important topic about patient safety. And I always wonder why we don't talk about it more, both in, of course, the healthcare settings, but also in patient organizations as well as the life science industry. I think patient safety is concern or a topic for us all to discuss and to improve. So I hope we all will have a very nice and interesting day with a lot of networking. I think this is such a good opportunity to network and to learn from each other. So to have this kind of opportunity to meet also people from different countries is really something that I personally like a lot, because it always gives you new friends and new thoughts, new ideas. So very, very welcome. And I will leave the word also to my colleagues here.
Ladies and gentlemen, welcome here from my side in this beautiful Van Swieten Saal. It's a very historic hall. Thanks to Pernilla and Michael Wagner for organizing this conference together with the Austrian Network for Patient Safety. The Austrian Network for Patient Safety is an independent national network with the aim of promoting patient safety and employee safety by offering projects, research, networking and information. So, what happened since the Austrian Network for Patient Safety was founded in 2018? First of all, there's a positive development insofar as we know a lot more about patient safety, employee safety, safety culture, risk management than we did 15 years ago. However, when we take a closer look at the positive results of numerous research projects and ask ourselves, has it been possible to put these results of numerous research projects and studies into practice? I, for my part, would come to the conclusion that just some of them actually have. Unfortunately, the situation is clear. We don't want to frighten anyone, but patient safety, employee safety, which also means their safety, is important to us. This topic is discussed far too little and needs to become much more prominent in the awareness of everyone involved. All the studies carried out to date paint a clear picture. In Austria, around 1,000 people die every year as a result of medical errors, and up to 4,000 die from infections with hospital germs. At least a third of these fatalities could be prevented. Studies show that significant progress in patient safety and health outcome is achieved when patients are recognized as partner in their care. This is why the WHO dedicated this year's International Patient Safety Day to patient engagement. International studies show that around 1 in 10 people who are treated as patients in healthcare facilities suffers harm. But by now, we know that at least 50% of this harm is preventable. And we also know that the impact of patient engagement in safeguarding patient safety is considerable. Its implementation can reduce the burden of harm by 15%, which means that we could save countless lives every year. From a study OECD from 2017, we know that 15% of total hospital activity and expenditure is a direct result of adverse events. We have to keep in mind that not only suffering for patients and relatives could be reduced, but by trying to avoid harm, financial resources for the healthcare system could be freed up as well. The well-being and safety of healthcare workers must be important to us, especially at a time when there is already a noticeable shortage of healthcare professionals. As a result of this shortage and consequently overloaded medical services, we are losing well-trained and qualified healthcare workers, which also increases the risk of more errors occurring. Therefore, it's a high time for us to support our healthcare professionals. Patient safety is a task we have to tackle together. Let me finish by expressing my hope that we'll have an informative and exciting conference here in the von Vieten Hall with lots of input and inspiration for your daily work. Thank you.
Hello everyone in wonderful Vienna at this beautiful place. My name is Michael Wagner. I'm the representative of the Medical University of Vienna and also board member of the European Patient Safety Foundation. First, I would like to thank my previous colleague Eva Schwind, who started this collaboration of Medical University of Vienna and the European Patient Safety Foundation. And I took over from her like last year. And then we started this to plan this conference from zero. It was pretty unclear what it will going to be, and I'm very happy to see a lot of people here and to have a very nice speakers list. I would also like to thank Mirka Tsikalova, who was doing a lot of work for this conference and planning a lot. I would also like to thank Penila and Brigitte and the Austrian Patient Safety Conference. And I hope that we will have a wonderful day, wonderful presentations. The mission of the EUPSF and from these days to collaborate, to learn from each other, to do networking, and to find common projects to improve patient safety. Last but not least, I would also like to invite you to the networking event tonight. So we have a lot of registered participants already, but there are some free spots. There will be a tour at the Josephinum Museum. Afterwards, there will be a very nice concert from people from the Medical University of Vienna. And there will be a lot of possibilities to exchange, to network, to get to know each other, and to plan future projects. So I wish you a very nice day, and hopefully we will see each other later at the event.
Thank you so much, Brigitte and Michael. We are now having a virtual presentation from Professor Natasha Atsupardi-Muscat. She is the director of the Division of Country Health Policies and Systems at the World Health Organization.
Ladies and gentlemen, colleagues and friends, good morning and welcome to today's event. We find ourselves in a time of perma-crisis. We are facing permanent and relapsing crises with huge health impacts. Our healthcare systems were already under immense pressure before the pandemic struck, but the arrival of COVID-19 and now conflict too have laid bare our vulnerabilities in the harshest light. We failed to protect the most vulnerable. Our preparedness plans proved inadequate, and our surge capacities were insufficient to deliver the high-quality care our communities needed. It took a global crisis to accelerate our adoption of digital solutions and new health service delivery methods. These lessons, hard learned, have become the building blocks of our resolve. Investing in and transforming primary healthcare is crucial. Primary healthcare services are at the heart of healthcare in many countries. They provide an entry point into the health system and directly impact people's well-being and their use of other health and care resources. Low quality, unsafe, or ineffective primary care may increase morbidity and preventable mortality and may lead to the unnecessary use of scarce hospital and specialist resources. Thus, improving quality and safety in primary care is essential when we strive to achieve universal health coverage and the sustainability of healthcare. And we do not talk about this enough. We cannot achieve universal health coverage without improving and ensuring quality of care in primary care. We must equip these facilities and make the necessary investments to enable primary healthcare professionals to provide high-quality care. And we also must ensure proper collaboration and support between all levels of the health system. For this reason, our health infrastructure, including hospitals, must evolve to meet the ever-changing needs of patients and providers. This involves reducing waiting times for procedures, enhancing patient experience and satisfaction, and being open to embrace new technologies and practices. Initial findings from our forthcoming first report on quality of care and patient safety across the European region highlight that while almost 2/3 of countries have or are developing national plans on quality of care and patient safety, there is an urgent need to consolidate national frameworks region-wide. We find that most countries focus on access, efficiency, and equity, while fewer take into consideration people-centeredness. Overall, only 18 countries out of 53 across the region have reported having fully functional, comprehensive action plans on quality of care, and only 17 on patient safety, while still fewer, only 7 countries report patient voices are recognized within quality and health governance mechanisms. Unfortunately, almost half of the countries included in the survey lack data on effectiveness and patient safety. A critical lesson we've learned during these times is that we cannot improve something that we cannot measure. We need data and we need to measure what matters, and this is what this report will set out. Our report also finds that most countries have national plans to combat antimicrobial resistance. A clear indication of their dedication to tackling this issue is the recent adoption of the WHO Europe AMR roadmap at the 73rd session of the WHO Regional Committee held in Kazakhstan last month. The roadmap includes significant action points on quality of care and patient safety. On another front, another crisis, an internal crisis, is being uncovered: the health and care workforce crisis. Our healthcare and caregiving professionals are exhausted. They've been pleading for urgent support and protection. It's vital to understand that if we do not support those who deliver care, we cannot guarantee safe care for all. Quality of care and patient safety hinges on the hands of skilled professionals. Unsafe medication practices and medication errors stand as a prominent cause of avoidable harm in healthcare worldwide. More than 20% of medication errors can, however, be attributed to excessive workloads and understaffing. Health professionals involved in such adverse events, often referred to as second victims, may endure severe emotional trauma. During the COVID-19 pandemic, over 1 in 10 nurses experiencing mental and psychological conditions were implicated in an adverse event with dire consequences for the patient. The newly adopted Framework for Action on the Health and Care Workforce, adopted in Astana last month, will guide countries in tackling this challenge. Lastly, all our efforts remain in vain until we rebuild the trust that many have lost over the past years. To achieve this, it is crucial that we involve patients and their caregivers in the decisions that directly affect them. We are currently grappling with a loss of trust in several key areas. A loss of trust among the public, who doubt that the health system will be there when they need it. A loss of trust among the health and care workforce, who remain skeptical about whether the health system truly values them. A loss of trust among politicians who question the ability of health systems to modernize and adapt to meet evolving health needs. Even before the COVID-19 crisis shook people's faith, we recognize the pivotal role trust plays in strengthening our health systems. This is precisely why trust and transformation will take center stage at our upcoming Health Systems Conference in Tallinn, in Estonia, in December. In Tallinn, we will also discuss the evolving role of digital technologies in healthcare. As you are all aware, the pandemic also accelerated the adoption of digital tools and new service delivery methods. Whilst these hold great promise if used correctly, they can also have a significant impact on patient safety. We must look carefully into this area to ensure that the technologies that we use are safe and effective, much in the same way as we do with medicines and devices. Our digital health and quality of care teams are working together to develop tools to contribute to quality and patient safety in the context of telehealth initiatives. In conclusion, I would like to reiterate that we are at a crossroads, facing multiple crises that directly impact quality of care and patient safety. We are making strides in advancing this agenda, working collaboratively with countries to address these challenges through our new network of WHO European focal points on patient safety. Coordinated actions towards strengthening quality of care and patient safety and reducing the data and knowledge gaps will serve to support the necessary transformation of healthcare systems, reducing inequalities and having us better prepared to face the challenges. These endeavors will ensure the well-being of patients and their safety, and the resilience of our health systems in the face of future challenges. Thank you for your commitment and dedication to discuss and tackle these critical issues, and I wish you a productive and enjoyable meeting.
Thank you to Natasha, and now we have a keynote speaker on site, and I'm very happy to introduce Dr. Anthony Staines, very well known for your work in patient safety. So the floor is yours. Welcome.
Thank you very much. So I was invited to speak about the reasons why we need to keep patient safety on the agenda. Could I have my slides up? That would be fine. Okay. Here we are. Thank you very much. Sorry about that. So I believe why we should keep the topic of patient safety on the agenda is a very legitimate question, because the 2 Ares Human Report was published 24 years ago. Ages. Is it still relevant to have patient safety on our agenda? Surely most of the issues that were raised by the 2 Ares Human Report must have been solved. Currently, we need all of our resources to survive the convergence of multiple crises that we are facing. So why do we need to keep patient safety on the agenda? Well, let me share with you why I believe we should not only keep patient safety on the agenda, but put it actually on the top of the agenda. First of all, an enormous burden of harm remains, linked to unsafe care. You probably remember the results of the Harvard Medical Practice Study carried out on hospital stays in the US in 1984 and published in 1991 in the New England Journal of Medicine. It says that 3.7% of hospital stays are contained an adverse event. In 1999, the 2 Ares Human Report used these figures and those of another similar study in Colorado showing 2.9% adverse events. In these studies, adverse events are defined as clinical incidents where there is harm to patients, leading to at least a prolonged hospital stay or more serious harm. In 2023, Bates and colleagues published a new study in the same journal showing that adverse events had occurred in 23.6% of hospitalizations and serious adverse events in 7.5% of hospitalizations. This leads me to the following comments. All of these studies are respected by the scientific community. I see that between 1999 and 2023, the definition of harm has widened. In 1999, if I injected a patient with 10 times the dose of anticoagulants, resulting in a massive epistaxis, the patient was administered vitamin K and was stable 5 hours later. That would not count as an adverse event in the studies that I just mentioned. In 2023, it falls in the adverse event category, just not in the serious adverse event category. The last comment is that despite numerous programs to improve patient safety, numerous regulations, bodies, agencies having been set up, harm has not decreased in this environment. And from what I see in the European environment, the situation is fairly similar. The type of studies shown in the previous slides has been replicated in many countries. And there is now scientific consensus that in high-income countries, 1 in 10 patients is seriously harmed whilst receiving hospital care. It therefore follows that patient safety is a global health priority that requires urgent action from countries, institutions, and providers. On top of the burden of harm, there is also a substantial economic burden. The OECD estimates that 15% of hospital expenditure and activity can be attributed to treating safety failures. Another word for this is waste. Another cost of patient safety failure is the loss of trust in the health system and in governments, as the COVID-19 pandemic has illustrated. The Edelman Trust Barometer report of 2022 shows that 52% of the respondents over 9 countries in the survey, the pandemic has decreased confidence in the healthcare systems and its and in its ability to handle major crises. The 2021 World Happiness Report has correlated fewer COVID-19 deaths with higher trust in public institutions and greater income equality. So you can see the vicious circle of safety failures leading to loss of trust and loss of trust leading to behaviors that increase risks. Since the 2 Ares Human Report, we have witnessed a rapid and substantial expansion of the solutions for patient safety issues, and also of the evidence behind each solution. The body of knowledge has massively developed, as illustrated by the literature reviews carried out by the Agency for Healthcare Research and Quality in the US. The problem is not knowledge about what to do. The problem is the implementation in daily practice. In my region in Switzerland, in 2015, we discovered that the hospitals had a hand hygiene compliance of 62%. At the same time, we surveyed the staff, and the staff believed their hand hygiene compliance was 87%. Yes, until we measure compliance to our best practice, we tend to overestimate our performance. Research shows that it takes on average 17 years for a scientific discovery that improves safety to be implemented in routine clinical practice. Let's face it, we have a chronic weakness on implementation. Our major weakness is not lack of knowledge, it's our lack of ability to systematically and reliably implement the knowledge at our disposal. We are very much in need for new knowledge around best practice in the process of implementation. Disseminating, mandating, and hoping is not enough to implement evidence. Implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. It takes us through steps to understand, 1, who needs to do what differently, 2, what factors determine whether or not they do it, 3, which strategies can be effective to target these behaviors, and 4, how to measure outcome. A crisis such as the COVID-19 pandemic also reveals the status of patient safety in healthcare institutions. I chair a group of patient safety officers from the Hospital Federation for which I work. I vividly remember a video conference with them in March 2020, just 2 weeks into COVID. About half of them had been sent home, deemed non-essential, and they had been told that their patient safety program was hibernated until further notice, as no one would find time to work on patient safety during the crisis. Other patient safety officers had reinvented their job description and were contributing by gathering evidence on COVID, by setting up just-in-time training and simulation, by advising and supporting leadership, by providing staff safety, etc. My observation was that the hospitals where the patient safety officers was a member of the board were those who were most likely to find ways to reinvent the mission of patient safety teams. And those where patient safety officers were just in a lower position in the hierarchy found it much more difficult. The role of boards of trustees in governing towards patient safety is also an issue why we need to keep patient safety high on the agenda. I believe we have a lot to do in raising awareness about patient safety at the board of trustee level. I'm always amazed to see the filtering process when news go up the hierarchy. Bad news are so much more likely to be filtered out than good news. So we should not be surprised that members of supervisory boards have an overly optimistic perspective of quality and safety in their institution. Ashish Jha from Harvard has surveyed chairs of hospital boards in the US and in England. These chairs could assess the quality of their hospitals versus other hospitals in the country, choosing between 5 responses: much better quality than average, better quality than average, average quality, worse, or much worse. 66% of the board chairs chose much better or better quality, with only 1 to 2% choosing worse of much or much worse. So of course, we should not be surprised, we should be worried, because these are the people deciding on patient safety resources. In Switzerland, I'm part of a team that has set up a one-day seminar to raise awareness about quality and safety of care of members of boards of trustees. So we issue an online survey 6 weeks before the seminar, and we ask the following question. We define an adverse event as serious harm and ask how frequently the participants believe it happens in acute care hospitals, providing choices for their response. As you can see, half of them believe that it happens for 1 out of 1,000 patients or less frequently. So, of course, if this were the case, there is no need to discuss the issue at the board level. But if it's 1 patient in 10, then of course it needs to be discussed. Another reason to keep patient safety on the agenda is the progress we still have to make in improving our clinical information systems. Electronic patient records can help prevent adverse events. Some have much more advanced capabilities than others. This here is just an example. Klassen and colleagues scored multiple electronic patient records over a 10-year period in the US. Alerting for drug-drug interaction is a common feature, but drug age compatibility or drug diagnosis plausibility is still underperforming and underdeveloped. There would, of course, be many more examples of untapped IT support for patient safety. Expectations from the population are rising. The quest for accountability is increasing. Accreditation agencies incorporate patient safety more and more into their standards. Regulators and health authorities strengthen their requirements. Keeping patient safety high on the agenda can help complying with these standards and requirements. And also new laws appear reflecting societal expectations, like for example here in Italy, where patient safety has been recognized as a fundamental human right. The healthcare landscape is evolving rapidly. New technologies, new treatments, new delivery models are appearing. Those presented here are merely a few examples. All of these bring solutions to health and healthcare problems, but they also bring new risks, new complexity, increased needs for coordination, increased challenges for patient safety. And the COVID-19 pandemic has taught us that there is no patient safety without healthcare worker safety. Our healthcare systems have been overstretched and workers have tirelessly coped with difficult circumstances, long hours, fatigue, burnout, psychological distress have been emphasized during COVID. Fatigue and a loss of meaning have remained after COVID. We really need to invest in staff well-being to fight fatigue, and we believe that investing in patient safety and staff well-being will bring meaning and resilience to our healthcare systems. Patient engagement for patient safety is becoming more and more recognized for its potential. The WHO set up its Patients for Patient Safety initiative in 2005. Along the years, it has shown its potential, and that potential is becoming mainstream. In 2023, an OECD report focuses on patient engagement and brings recommendations that can boost patient safety. Here are the recommendations. Also, after more than 20 years of work on patient safety, it's possibly time to rethink patient safety. Healthcare Excellence Canada has recently published a guide for patients, providers, and leaders to discuss items about patient safety, such as, for example, the definition of harm. Should it no longer focus solely on physical harm, but also include psychological harm or systemic inequalities or inequities? Should we not only look at what went wrong, but also learn from what went well? 23 years after the To Err is Human report, do we still have the right momentum, the right sense of urgency? Well, recently, a group of patients active in patient safety raised the issue with a wake-up call paper entitled "Who Killed Patient Safety?" They argue that patient safety has withered over the past 10 to 15 years, that there has been no global reduction of harm, that patient safety weakened during COVID-19, that safety in healthcare is not at the level we could expect looking at other industries, such as aviation, and that organizations who used to lead patient safety, oversee, support, have moved to other priorities. And last but not least, there is in the reasons why we should keep patient safety on the agenda is the ethical imperative. Citizens and patients come to us in healthcare with the need to be supported, to receive care, with the hope to be cured. First, do no harm should continue to be our guiding principle, as it has been for the past 2,000 years. We owe this to our patients, and we should consider harm to patients as unacceptable. As WHO's Director General said at the Global Ministerial Summit on Patient Safety in Montreux this year, if it's not safe, it's not care. Thank you.
Thank you so much, Anthony, and we are looking forward to the rest also of the program, but you have really set the scene for our coming discussions today, so thank you so much.